Good morning and good afternoon to everyone. I'm Miriam Rabkin, the Director of Health Systems Strategies at ICAP Columbia. I'm delighted to welcome you to this, what we hope will be a really interactive discussion of differentiated service delivery for people living with HIV in cities. Sort of a new topic in differentiated care for us. We're organizing this centrally, so one person is advancing the slide. So you'll hear us say advance slides, and Mike, could you advance me to the next slide? Thank you. So this webinar is part of our CQUIN project. CQUIN stands for Coverage, Quality, and Impact Network, and it's a Gates-funded learning network focusing on differentiated service delivery. So what we're doing today is what's in this red box here. It's a fun part of the network to link providers and implementers and policymakers together to talk about successful or innovative or new differentiated service delivery models. And that's what we'll be doing this morning. Next slide. So CQUIN exchanges best practices in lots of different ways. We have a website. Some of you may be familiar with it, but the address is up here. We have webinars like this one and also webinars that are more formal expert presentations. We have a journal club, a lot of resources on that website. We also have in-person workshops and meetings. We have virtual communities of practice, and we have we have south-to-south visits and learning exchange, and we're always looking for new ways to share experiences and lessons learned. So if you have ideas, let us know. Next slide. Today we're going to have short case studies. So we've instructed our presenters to keep their talks to 10 minutes, which is the most difficult length of a presentation. So they're not going to go into depth because we want to leave time for questions. But we're really excited that we'll have for you today presentations from Zambia, from South Africa, and also from Malawi. Next slide. Okay, if you're not, yep, thank you. Whoever just muted themselves, thank you. So the topic for today is urban differentiated service delivery, which isn't really usually part of the classic decision frameworks, but one of the things that we've noticed as we're learning from one another and hearing about DSD in different countries is that some of the sort of classic DSD models like community antiretroviral groups and other sort of typical, what we might typically think of as DSD, work variably, whether we're talking about rural, semi-urban, or urban populations. And so we sort of have the opportunity to convene this discussion to start thinking about what is it that may be different about cities and what are some models that implementers have initiated or experimented with to really to meet that need. Next slide, please. So today I'm delighted to introduce three speakers. I'm going to introduce them up front, and then they're just going to each give a presentation one after another. If you have questions during their presentations, you can type them in the chat box, and I'll read them out later. Also, at the end of the last presentation, you can either type questions in the chat box, or if you're on video, you can raise your hand, and Laura will find you, and you can ask questions on verbally, or if you want to, if you're on the phone and you want to ask a question, you can just sort of say in the chat box, you know, hey, Laura, because we really want you to be able to ask these experts questions. So we're delighted to introduce Michael Odo, who is the technical advisor for HIV care and treatment for the Department of HIV/AIDS at the Malawi Ministry of Health. And Dr. Odo is going to present a model called drop-in centers for female sex workers in urban Malawi. Then we'll hear from Phil Roberts, who's the CCMDD project lead at Last Mile in South Africa, and he'll present on an innovative shipping container solution for chronic medicine pickup points in urban South Africa. And then finally, we'll hear from Mpande Mukumbwa Monichanya, who's the manager for the community ART for retention study at CIDERS in Zambia. And she's going to present a model called the Urban Adherence Group that CIDERS has developed and really tweaked and tailored for people living in cities. So with no further ado, I'm going to ask Mike to advance the slides to our first presentation and metaphorically hand the microphone over to Michael Odo.
Thanks so much, Miriam, for that wonderful introduction, and thanks to the CQUIN team for the opportunity to share this model of care and treatment practice in our urban and suburban area, um, focused on female sex workers. Next slide, Michael. So Malawi is a small country, 17.4 million, about 1 million people living with HIV and AIDS. And we are doing pretty well with the UNAIDS 1990 targets. Current adult prevalence is about 9.7% from Spectrum estimate, and our incidence is dropping comparatively and reasonably well at that. For adults at 2.4% and for children 0.9%. But for the key population, as it is with other countries, there's a disproportionately much higher incidence and prevalence rates that continues to fuel transmission in the society from the hotspots where they operate. And the last prevalence rate for female sex workers that we have was at 2014 and at 62.7%. It hasn't changed very much by now. Next slide. So drop-in centers is a model that is recognized in the National Strategic Plan and is currently promoted in 6 districts in Malawi, and I just showed them in the map there. Next slide. So basically, I've put up there because of the limitation of time to do a bit of elaborate description, showing the framework which we use for the drop-in centers, a network of processes, systems, and structures, essentially telling from the root. You see the Ministry of Health, the National AIDS Commission, and the DHA. All of these 3 institutions provide a policy framework upon which the 3 civil society organizations that are indicated there, Pakachere, UNECO, and SEDEP, carefully and nicely link up with the health facilities and the lab systems that provide the support for the prevention services that is noted on the left and the treatment, care and support services that are indicated on the right. But interestingly, all of these are nicely linked to provide a good enabling environment that provides good access and encourages female sex workers and other key populations to access service. So human rights is protected, gender equality is promoted, and there is absolutely zero tolerance for stigma, discrimination, and violence. And this is an acceptable policy within the government system. So the police institutions, the Malawi Police Service, and other legal framework within the society are able to recognize and use it for female sex workers and other key pops that need their services. Next slide, Michael. So typically there are 4 modalities for providing services for key population, and I just put on red the drop-in centers, which is the subject of discussion in this webinar. But of course, there are outreach clinics where services are taken from time to time to provide services. They are not static. The hybrid scenario where the services are created within the regular health facilities. So key pops that want the services have no limitation in coming to have access, and then they work out without the typical congestion that happens in the regular clinic. And of course, the static one that is supported by the linkages project. Next slide, Michael. So this is a typical drop-in center that is shown here, and all of the package of services that are listed there for all key populations and the clients of female sex workers, the ones that are willing to, of course, accompany them. So prevention messages are typically provided: condoms, lubricants, HIV testing, STI screening, TB screening. And as I showed in the sketch before, all of these services, both prevention and treatment for those who are positive, are linked up nicely to the health facilities. So in terms of M&E flow and commodity flow, there is a bit of good security and linkage. Next slide. So I just showed the next two slides, the kind of structure that supports the framework we saw earlier on. A typical drop-in center will have a 3-man team made up of a nurse and clinicians who are well educated and trained on HIV services, testing services, and treatment services. And then is headed by a DIC manager. The DIC manager reports to the district coordinator. And in our situation, the district coordinator is the highest and most experienced HIV/AIDS service provider at district level. And then the other two persons, the receptionist and the HTS counselor, both of whom are not just educated and equipped with HIV services, but they also have the unique training and understanding in dealing with the peculiarities and social situations of key population and female sex workers in particular. We do not have much of an MSN situation or injection drug users as it is with other countries. Next slide. And then in the community, we have two categories of key POP members. The first one is the peer educator. Peer educator is typically ratioed in one peer educator to 40 peers, and they do mobilization and sensitization of their members and link them to the drop-in centers. And then the peer navigators that are specifically linked to those who are tested positive. So they provide adherence counseling and support them in ensuring that they go for viral load at the routine. And the policy for our country is first 6 months and then every 2 years. That's a little longer than the WHO recommendation. Next slide. I just showed a slide of what I can call an accomplishment in the 6 districts. This is pooled data from the 6 districts, and we can see quite a good number, approaching 10,000 that have been enrolled. About 43% of that were tested, but 43% were already positive as at the time of testing. And on the right side, you can see the treatment cascade. You find more number enrolled because of the snowball effect. Some of the female sex workers who are enrolled in treatment find it helpful to call other colleagues to go directly who are tested positive into treatment, and they are not part of the other cohorts that are originally indicated through testing. Next slide. Interesting as this be, with a limited time, that's just a quick summary, but there are some challenges and also successes. Challenges in key POPs access to health, there's still a bit of limitation. It's not everyone who finds it as easy and willing to participate in the drop-in centers. And I think this is because of the high level of stigma, still much community harassment on key population, and the high-risk behavior, especially among clients, male clients that insist on condomless sex, is still pretty a problem. But we're happy that on the success side, the capacity of CPOs have been built, and that's quite a huge lessons learned. The DICs that have been set up, and the fact that they link with the health facilities. So in terms of monitoring and evaluation, we are able to stay on top of the issues. It's still in 6 districts, so one can say it's a long way to go to the 28 districts. Next slide. I think this is the last slide. I want to acknowledge all of these partners that have worked with us at the Ministry of Health to make things work, and to also particularly appreciate CQUIN and all the colleagues that are out there making this work and giving us an opportunity to learn and share experience with other countries. I'll be very happy to take all the questions and comments that will be coming from the audience. Thank you.
Thank you, Michael. Not only was that a fabulous presentation, but it was meticulously on time. So we know how difficult that is, and we really appreciate it. Mike, if you could advance the slides, we'll move into Phil's presentation. Thank you. And Phil, you're muted, so you need to. Yep.
Right, here we go. All right, hi everybody, and welcome to all those people that are signing in that didn't attend the meeting in Maputo. So I'm going to deal through this quite quickly. It's a container, shipping container that we have utilized in a bespoke situation for assisting in patients getting medication, close to their place of work or close to their place of residence, and at the same time with the fundamental purpose of decongesting health facilities in South Africa. Okay, next slide, Mike. For those, just a quick reminder on how our centralized chronic medicines dispensing and distribution system works. Patients are given the opportunity, stable patients, chronic patients, that's HIV predominantly, and then diabetes, hypertension, epilepsy, are given the opportunity to collect their medications from external pickup points. And sometimes these external pickup points are not available in brick and mortar solutions. We use a combination of community pharmacies, retail centers, private doctors, etc. And in this case, where we placed this container, we didn't have a ready solution, and that is what initiated the genesis of this container process. Next one, Mike. This is what it looks like. It's a 40-foot container that has been modeled to act both as a pickup point, in this case a little bit over-engineered because it was also intended to be used as a sort of a primary healthcare. That's not what CCMDD is all about. So at this point in time and at this early stage, it will operate only as a pickup point, but it just gives you an idea of the flexibility of the unit, and it's either temporary or it's permanent. This one is more permanent, and it's in borrowed ground from a local retailer who doesn't charge us much for the rental of the area, and also provides the electricity, and water is self-contained in the unit through a reservoir. So that gives you a look at what it's like, wheelchair friendly, etc. Next slide. The interior is probably familiar to most of you that have worked in a pharmaceutical background or have a clinical background. Storage areas, shelving, security, wash-up area, and also security for medicines, security for patients. This is I just have to mention, is in partnership with CIPLA, a pharmaceutical organization, and with the National Department of Health, so a true private-public enterprise. Next one. So the purpose of the placement of this container was really just because the primary healthcare facility did not have a ready solution. A lot of patients were trapped literally in long queues to try to renew prescriptions, and we agreed to do a proof of concept with CIPLA on this container in an urban area, high population, high patient counts, high mobility, but not able to really find solutions that were acceptable to both patients and to the department. And the principle here is to try and scale it as quickly as possible. We're talking about 100 units over the next couple of months. Okay, next slide. This is some of the features. You can see all of the good things that relate to both patient comfort, clinician comfort, and medicine safety and security. So we have all the cupboards, we have the water, we have refrigerations where necessary, where we are doing thermo products. And then the design of the container is to ensure that we do get a very efficient flow and productive service of the patients, and the average waiting time should not be more than about 12 minutes, which is remarkable given that the average waiting time of a CCMDD patient in a primary health facility is anywhere between 4 and 7 hours. Next slide. The benefits, it's a chronic medicine pickup point. Eventually, it should evolve to also become a primary healthcare facility offering very basic clinical support. Not the intention immediately, but certainly down the line. Everybody has shipping containers, whether you're landlocked or whether you have a port, they are there, so they're easily convertible. They are fully turnkey and can be placed pretty much wherever you have space and security, and it's definitely scalable. The capital outlay is relatively low in comparison to bricks and mortar solutions, or particularly in urban areas where you're paying high rents and not always getting the ideal facilities. And it complies most importantly with good pharmacy practice. And it is an empowerment process by engaging with local community and providing some employment for some of the local community. Next one. I'm not going to go through all the process. I think I'm pretty much heading on time, but we do identify where these containers need to be placed by doing geomapping assessments, looking at the burden of disease, the patient demographic, looking at locations of primary health care relative to established formal businesses, that's either retail or doctors, pharmacies, and other clinics. And then it also requires quite an extensive amount of negotiation with all the parties. As you can imagine, the Department of Health, the local provincial governments, the local district governors, and the local primary health care also needs to be fully bought into the process so that they have comfort and trust in recommending their patients to the pickup point. Okay, next one. Just a quick view of the map. How did we know and how did we decide where the shipping container would go in relation to both of the patient population as well as the existing primary health care, so we could know where it was going to be fed its patients from? Next one. This is how it's grown since November 17. You can see word of mouth, because there's no marketing per se. This is very much a peer marketing initiative. So people will have a good experience, will tell fellow patients that are stable and meet the criteria about the facility. So you can see there's a very strong organic growth there. And this is for all chronic medicines under the CCMDD banner, which is antiretrovirals, diabetes, hypertension, epilepsy, and in some cases, some of the cold chain product as well. So talking about insulin and in also some instances asthma. Next one. And that's it. That's a very quick whirlwind tour of the container model, which we are in the process now of looking at scaling out through South Africa's urban and then also into some rural territories as well. Thank you very much.
Great, thanks, Phil. And I should tell people that that was really a whirlwind tour, but Phil is also giving an hour-long grand rounds on May 22nd. So you'll see information about that and how to get more details. I think there's also a couple of questions in the chat box for Phil, and I'll come back to those. But in the meantime, we'll switch to Mpande and hear our third case study.
All right, thank you, Miriam, for that. I'd just like to say thank you to CQUIN for giving us this opportunity to share our findings from model implementation of urban adherence groups in Zambia. Next slide, please. So, overview of my presentation, I'll just quickly run through the background of this community arity study, and I'll go into the actual model itself, and lastly, open up for questions. Next slide, please. So the motivations for differentiated care in Zambia, I'm sure, are the same motivations everywhere else, but as in 2013, Zambia care delivery had reached status, and really it was one size fits all approach. And what we noticed is that continuous retention 2 years after ART initiation was suboptimal at 58%. And really at the time, there was limited experimentation with community-based delivery and differentiated care models. Next slide, please. So in 2015, the Bill and Melinda Gates Foundation funded CIDE's differentiated care study, which we're calling Community ART, and we had two main aims. And the first main aim was really just to rapidly assess the local preferences for various elements and attributes to the differentiated models and create a toolkit for use in other settings. So under this objective, we conducted formative activities, which are IDIs, focus group discussions, with different stakeholders. And we also did surveys and discrete choice experiments. Next slide, please. The second aim really was just a rigorous evaluation of feasibility effectiveness and cost effectiveness of 4 differentiated care models. And the main outcome for these models was retention in care, and the secondary outcome was looking at viral load suppression, cost effectiveness. Next slide, please. The eligibility criteria for enrollment into these DSD models, the target really was stable patients whom we defined as HIV positive adolescent and adults greater than 14 years of age, should have had a CD4 count of greater than 200. And if the CD4 count was not available, the clinician at the facility could determine whether the patient was stable. And the patient were not supposed to be acutely ill, and it was for ART patients on treatment for at least 6 months. Next slide, please. So this is just an infographic just showing what this model, the urban adherence group, we called it urban adherence group as opposed to urban adherence clubs. But really the group is of 30 stable HIV patients from the same community. And every 2 to 3 months, the members meet at the clinic for adherence support, symptom screen, and drug dispensation after clinic hours. So these meetings really, the way we had planned it is that it should take roughly about 45 to an hour. And then every 6 months, according to the standard of care, the patients would come to the clinic for full clinical visits. However, they would continue to collect drugs in their UAG meetings. Next slide, please. So here I'm just presenting some emerging findings. So in terms of acceptance, we had high acceptance despite continuing concerns about additional human resource needed to support these meetings outside clinic hours. So each of these meetings was supported by a pharmacy technologist, a lay health care worker, and what we had, a community liaison officer. And what we, other findings is that model and audience specific communication perceived as important for successful implementation. Then at baseline, what was found was that patients were worried about involuntary disclosure and stigma due to the large group size. But during implementation and after implementation, this was not reported. And also there's need for local authority to adapt these UAGs for them to remain responsive, effective, and sustainable. Next slide, please. So this slide is just from patients, just showing that they value the UAGs for their social support and convenience. I will not read the quotes in detail in the interest of time. Next slide, please. This is emerging findings for AIM2. So the group meetings were generally well attended, although in nearly a third we had missed meetings. But however, patients, they picked up their drugs using other means. Either they had a buddy that picked up their drugs or they picked them after a meeting. And what we have seen from our preliminary analysis is that 12-month cumulative incidence of greater than 7 days late pharmacy visit was lower in the intervention arm as compared to the control arm. So we are currently also doing further analyses and mixed effects regression, which will be conducted for 12-month cumulative incidence of missed pharmacy visits, which we're defining as greater than 7, greater than 14, and greater than 28 days late. Next slide, please. So this is just Kaplan-Meier failure estimates, just showing what I've explained in the previous slide, showing that the intervention, the incidence rate was lower in the intervention as compared to the control. Next slide, please. Next slide, please. So what lessons did we learn whilst implementing these UAGs? Overall, sorry, previous slide. Overall, patients missed their clinical visits because it's not part of the UAG meeting. So as I said, the way we had structured them, the patients attended their 3 months UAG meetings, but went to the clinic every 6 months for clinical visits. And also short expiry drugs affected the meeting schedule, so we had to adjust an event where we had short expiry drugs. And then also there was slow transitioning from standard of care to UAG. This was seen particularly in the first few meetings, but with consequent meetings, people attended. We saw high attendance. Then for the enrollments, the weekends were more popular off weekdays. So the way this model was structured is that we could either have the meeting during the week, but after clinic hours, and also over weekends. But the weekend option was much more popular. Then for meeting logistics, it was difficult acquiring meeting space to accommodate the group size, as maybe I think this applies to most of the facilities in most of the countries, but in Zambia, most of our ART clinics are really small, and there's a problem with space. And also we had a difficulty in securing drug storage space. As I said, most of these meetings happened over weekends, and because of that, we had to actually withdraw the drugs from the pharmacy and secure them for the meeting during the weekend. And the meetings took longer than planned. So our initial plan was to have meetings run from about 45 to about an hour, but in certain instances, some of these meetings took more than 2 hours. And the reason was that sometimes patients came late, but for other patients, because of that social support, they found this more as a chill, a hangout. So it was a place where they could go and hang out and, discuss other things, that were relating to the HIV care. And in terms of attendance, during the rainy season, we noticed that we had a lower attendance as opposed to the other periods, because if rains on that day, if there were rains during a meeting, it posed a challenge to them coming to the meeting. Next slide, please. Next slide, please. So what are our recommendations from this model implementation? One of the key things is that patient-centeredness is very important. You need to be flexible regarding the meeting day. So for us, we had most of our meetings, much as we are planned outside clinic hours during the weekday, we had more, we had to accommodate for more meetings over the weekends. And the time and group of composition, so with some of our groups, we could actually have adolescents only, or couples only, or women only group. And also encourage a buddy system among group members. So this is something that we noticed that for some patients that missed their meeting, they actually sent a buddy. Oops, Daisy. Thank you. They actually sent a buddy to actually collect their drugs, and also set up an appointment reminders for the patients, especially as you are starting out these meetings, because patients forget that they are having these meetings. But as they get used to coming for these meetings, the reminders are not necessary. And also having a clinician or nurse present at these meetings, because we did not have a clinician or nurse present, the patients actually missed going for a clinical visit. And one of the things that could also, recommendation is that integrate dispensation of chronic care medication. The other recommendation is sensitization and engagement. This is key, especially ongoing sensitization for all stakeholders, very important. And human resources, also HRH task shifting, and also investment in staff training and development, and appropriate scheduling or compensation arrangements for staff working over weekends or off hours. So because these meetings were conducted over weekends or off hours, staff need a compensation for, as this is over time. Then drug supply, ensure that you have adequate drug supply and with long expiry. And also labs are essential for patient management. And lastly, the monitoring and evaluation, very important as well. Create appropriate community and facility tools with staff trained. Next slide. Next slide, please. So thank you very much, CQUIN, for giving us this opportunity to present these findings. And before I end, before I hand over to Miriam, I'd just like to mention that we have a web-based toolkit coming soon with all our findings from this study. So this toolkit is designed to be user-friendly and will capture the Zambian experience of implementing these different models. So it will be hosted by CIDES and will be shared by IAF at www.differentiatedcare.org. So thank you once again for all those that managed to join this webinar. Thank you, Miriam.
Great. Thanks to all three presenters. You were spectacularly on time. We're so grateful because we have a lot of time for questions. So there are about 40 people online, and we have a series of questions. I'm going to read the ones that have already come in, and I'll direct them towards particular presenters. If anyone wants to ask a question just on video rather than texting it, sort of either wave your hand so Laura can see you, or just say so in the chat box, and we'll give you microphone rights. But so there are a lot of questions for Phil about the mechanics of the container solution. So I'm going to sort of, Phil, if you could sort of take notes. I'm going to go back to sort of give them all to you at once, and then you can decide how to organize your response. So there's some questions about the package of services. So is counseling included in this package? And are pregnant and breastfeeding women and children also do they also access this container model? There are questions about so that someone said, when are the CCMDD clients reviewed by clinicians? That was the second sort of category of question. There was a question about who's responsible for the security of the container. And then there were questions about how do you track the data on pickups, and how does that information get back to the primary care providers? And then the last question was whether you know the average unit cost of delivery versus the health facility model. That's a lot of questions. So Phil, I'm going to give you the privilege of saying tune into my webinar if you don't want to go through all of them. But there's clearly a lot of interest. So we'll let you answer some of those questions.
Yeah, okay, tune into my webinar, thank you. No, look, it's, yes, so what happens, and if I explain the process just very briefly, then that will answer a lot of the questions. The one is that the patients that are counseled to have the option to go to a CCMDD pickup point are stable patients. So they have displayed behavior and adherence patterns that gives the clinician a sense of comfort that they will continue to be adherent and honest to the medicine. So that's the first thing. Then immediately that they choose to go to this pickup point, their prescription, which would normally have been issued by the primary health facility, is then sent to a pharmaceutical courier company, and they effectively then become the patient's support base. They will receive a SMS 2 days prior to their medicines being delivered to the pickup point. They've got 7 days to collect their medication. After 48 hours, if they haven't collected, an alert is sent both to the primary health care and to the pharmacy courier that Phil Roberts hasn't collected his medicine yet. After 4 days, a tracing is done, a very top level mechanism of tracing is done of the patient, why they haven't collected, and after 7 days, the medicine is returned back to the courier company. And then we have to use our community health workers to go and find out the reasons why. And sometimes people have just relocated, sometimes people are terminal, and sometimes people literally have just died. So that's the one thing. Security at the container, generally, because it's a community-based initiative, we generally find that the security around the container is fairly, what's the right word, is fairly low-key. The container itself has, because it's a metal structure, has its own internal security mechanisms and external security mechanisms. So it has the required burglar bars, and it's very difficult to break into it. And there's the medicine that's carried there is generally, there is a currency of for the medicine in terms of people wanting to break in. But generally, so far, so good. And we find that people are more protective of what works for them in the community than if it was just something that had been placed there without their direct involvement. No, we don't do maternal, postnatal child breastfeeding because we're only dealing with adult populations deemed to be stable. Sometime down the line that may happen, I'm not sure, but right now we're focusing on just trying to break the back of a very large burden of people living with HIV who are not adherent because it takes so long to get their medication. Adherence rates in these CCMDD pickup points is about 98%. If it was at a primary health care, the average is around about 78%. So a significant increase in adherence because of it's easier, it's less time, and it's more productive. They don't have to take a day off work to collect the medication. The cost of treating at CCMDD, if you take the sunk and overhead cost of a facility, it costs about, in rand terms, I'll give it to you in dollar terms roughly, it's about $28 per visit versus roughly about $170 to visit at a primary healthcare facility. So, and those are, I will give you those exactly. We've done the empirical studies on all of this, both from a supply chain, clinical time, overhead cost, medicines cost, etc. I think I might have covered all of them now.
Yep.
And the package of services is, it's just a collection point. There's no counseling required at all because these people, the patients are stable. So I think I've covered them all, right, Miriam?
There are a couple more that came in. I'll loop back around if we have time, but otherwise we'll just put in another pitch for the webinar where you can hear more. There were two questions for Michael Odo. One was, how are clients linked to ART in this model? So is it done at the site or is it through referral to another site? That was one question. And then the other question had to do with whether, with the peer educators. So are all the peer educators HIV positive, or can they be HIV negative members of the key population, in this case, female sex workers?
Right, thank you very much. Typically, the peer navigators are HIV positive. The peer educators are just KPs. They are female sex workers. They may be HIV positive, they may not be HIV positive, because the safe environment created in the peer influence and the availability of the services in the drop-in center that is operated in an environment-friendly scenario is a key driver. But the peer navigators specifically are HIV positive and they are on ART. So they are able to provide adherence counseling for colleagues, the peer, other peers in KP that test positive.
Great, thank you. And then there was the question about the linkage to treatment.
Yeah, so it's the peer navigators and the peer educators that do the linkages.
Got it.
But like we explained in the presentation, the drop-in centers are staffed by trained people. These three folks are trained on ART, and it is a trained clinician and nurse who is actually the head. So the linkage happens with the peer educator and the peer navigator, but ultimately the provider of the service, both for HTS and ART, is the nurse, the trained clinician and nurse.
Great. Okay. Thank you very much. We also have a lot of questions from Pandey. So in no particular order, there are questions about how the urban adherence model deals with stigma. So this is from Joseph Kabanda. He says, in Uganda, such models aren't as popular for urban areas compared to rural areas due to stigma by clients in urban and suburban areas. And Pito from Swaziland also said your reported acceptance level for the urban adherence groups is excellent. Our experience in Swaziland is that urban patients resent associating into groups. How did you get elite urban residents to form groups so well? And then there were so that was sort of questions about how did you get people to convene? There were some practical questions also from Mpande, including what type of place do the urban adherence groups convene? I think you said, but this person says sort of, where does the meeting space? What is the role of the health facility in the meetings? There were also some questions about how do you organize data collection? And then there was, let me see, someone, Shelley asked, were there different groups based on age, considering that adolescents were eligible? So do you have like an adolescent urban adherence club or not? And then if you did, do you have any data on suppression and retention rates? Some of these questions are fairly complex, so we're actually going to share the email addresses of the presenters also, so you can have an ongoing dialogue. But Joseph also, so Yuri Matumono asked about organizing data collection. Joseph Kabanda also asked about whether data is collected from clients at the meeting, and then how does that data feed into the health facility data? So those are questions from Mpande, who needs to be unmuted. Okay, Mpande, you're still muted. So right. There we go. Okay. Now we can hear you.
All right, thank you for those questions. And in no particular order, I'll just answer each one of them. So how did we get people to join our groups? So one of the things that we did is that we actually had people talk about this model at the facilities. Every morning we had a peer educator who spoke about this UAG, and they had the infographics that I showed during the presentation, what this UAG is about and what what is required. So this was done every morning, and for patients that were actually interested, they would then go and see what we had, a community liaison officer. This was the person that was responsible for enrolling the patients and making sure that the patients select their preferred meeting time and meeting day. So this is how we did it, and we ensured that there was continuous sensitization with patients even after the enrollment. This is something that we continued doing with patients and also the healthcare workers. So that was that is the main approach that we did to ensure that we got people to join the groups. Then the question is the type and place of conducting these meetings. So these meetings, really, we conducted them at the health facility, but I know that they can also be done, in different, maybe perhaps in a school or maybe in a church in a community. But for our model, we actually just did this at a facility. Then the next question is, how did we organize the data collection? So during the meeting, we had a community liaison officer, and we had a peer educator, and we also had a farm tech. So the role of the peer educator was just to facilitate the group meeting, just to make, like maybe suggest a topic or maybe ask people what they could discuss, and he would facilitate, or he or she would facilitate the meeting. And then the community liaison officer, had what we called an attendance register, and that attendance register, we had particulars of the patient name, the ART ID, and also symptoms. We did brief symptom screening, and most of our symptom screening were, headache, yes or no, or cough, or related to screening for TB. And then, the last column was really drugs dispensed, yes or no. Then they would go to the pharmacy technologist, who would actually dispense the drug. So in the pharmacy technologist had the actual patient file. So in that patient file, we have a pharmacy form that feeds into the main electronic medical records. So it's a physical form, and it's then taken to the once the meeting was done, it was taken to the facility in the data room so that it would be updated to ensure that to make sure that it's captured that the patient actually came and collected the drugs. So that is how we organized our data collection in that way. We made sure that we tried to streamline it much as it was a study, but we had to make sure that we have it streamlined with what was currently pertaining in the facility. Then the next question is, did we have different groups based on age? So much as we had age group of greater than 14, we had very few adolescents that enrolled in this model. I think we had only one. And the reason is that really we amended our protocol, I think maybe 3 months after we had started enrollments. So we had very few adolescents enrolled in the model. So we have no data on adolescents. Then I think the last question is, I think that's about it. Oh, the last question is on stigma. How did we address stigma? So as I said, one of the things that we actually thought that there would be there would be stigma. And this is something that came out in our baseline FGDs and IDIs from the different stakeholders. But our experience once we implemented this model, it's something that we did not, we did not experience. And I think one of the things is that the continuous sensitization that we had going on is something that really assisted with helping out with the stigma. I think that's about it. I don't know if there are any other questions. Thanks, Miriam.
Great. So yeah, I just want to thank everybody. It's really a vibrant discussion. We also have just a teaser for future exchange, which is that Joseph Kabanda says in Uganda we have a very successful and interesting model on the use of community pharmacy spaces for drug refills for stable clients. So one way or another, we'll figure out how to share that information. I wanted to just we're sort of at the end of the hour, but I wanted to pull together a couple of observations and then just sort of give a couple of ideas about ways to continue this discussion. So I think what we've heard, we sort of started the hour by saying what's different about cities. And I think the presentations have highlighted some of the things that are different about people in cities, not necessarily people living with HIV in cities, but just people in cities in general. What are the challenges to service delivery? So Michael's presentation really highlighted that there may be more key populations in urban areas or more people who are more comfortable identifying as key populations in urban areas. I don't want to imply that there aren't key populations everywhere, but the sort of structure may be different in terms of service delivery. Phil's presentation illustrated that in some cities anyway, there are real issues with lack of space, and Mpande made the same point, which is that it sounds easy to say, well, just have community groups, but it actually may be quite tricky to find spaces to meet or to have spaces to dispense medication and sort of that connected to the container solution. And we all three presentations really highlighted the fact that social networks and sort of social behaviors may be different in cities. We didn't research this in particular in these case studies, but they touched on the idea that social networks may be different, that sort of perspectives on privacy and community may be a little bit different, that stigma may manifest itself differently in urban areas compared to rural areas, and those are things I think that we want to continue in the conversation. Michael's presentation also, for me, made the point that there may be much greater resources in terms of faith-based organizations, community-based organizations, non-governmental organizations in cities. That's not true in every country, but in some countries they're definitely clustered in cities and hard to find in the countryside. So that's sort of an asset to think about as we move forward. So I wanted to just really thank the presenters, not only for their fantastic work, but for their patience with our preparations and their adherence to our strict timing. We will share these presentations and a recording of the webinar on the CQUIN website. And I'm going to ask Laura to put the CQUIN website address in the chat box. We'll also send it around by email. There are case studies, as Mpande mentioned, on the website differentiatedcare.org. There are resources and guidelines and tools there as well. we do want to continue this conversation virtually. So as Joseph pointed out, there are lots of other models out there. So we'll probably plan a follow-up webinar, but in the meantime, if you have anything that you want to share, email it to us. We're going to have on the CQUIN website, we'll have the presentations and resources and also some publications, some information about other models, sort of all in a handy place together. So Mike has posted the CQUIN website address in the chat box. And with that, it's 9 o'clock here in New York, and I will thank everybody for their attendance.
Thank you, Miriam. Thank you.
Thank you, Miriam. Thank you, everybody.
Thanks, everyone.